Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
All right. So we have another guest lecturer here from the University of Michigan. She's Dr. Berna Saglik. Dr. Berna Saglik received a DDS from the Marmara University in Istanbul, Turkey, and a Master in Science in Prosthodontics from the University of Michigan in School of Dentistry in 2007. Upon graduation, she started working as a full-time faculty member. She's currently teaching in the graduate prosthodontic clinic, as well as directing removable partial denture course for sophomore dental students. She's also co-director of the dental postgraduate program in prosthodontics. She has received numerous teaching awards, including Dr. Paul Gibbons Award in 2010, the ADEA Council of Students, Residents, and Fellows Junior Faculty Award in 2011. She's also an alumni of the ADEA Leadership Institute. She's a member of the American College of Prosthodontics, the American Dental Education Association, and a fellow of the International College of Oral Implantologists. She's a published author with several peer-reviewed articles, and her area of specialization includes advanced prosthodontic procedures and dental implants. Thank you so much, Dr. Saglik, for being here. You speaking on the biomechanics of RPDs. RPDs, removable partial dentures, are not going away. Dr. Cooper is here. I've heard you talk about that, severally. And welcome. Thank you so much, Dr. Saglik.
You're very welcome. Thank you so much, Dr. Ugo, for putting this whole presentation together. Thank you so much, Dr. Ugo, for your kind introduction, and then actually thank you for putting this tremendous effort for putting this webinar series. So we're very proud of you as a Michigan faculty. And thank you all for zooming in on a Saturday afternoon, I assume, in Africa, and for those that are joining from US, thank you so much for zooming in today. So as Dr. Ugo mentioned, that I'm going to be talking about a very fun topic, depending on where you look at, about the biomechanical principles of the RPD design. So as Dr. Stralta mentioned, with the dental implants being really the high end of the treatment, removable partial denture is a conventional type of prosthesis. And then a lot of that still the application of the basic understanding and basic principles. So I'm going to just briefly touch up within the next 30-35 minutes about some information on these, how we can apply these biomechanical principles to the design as we go through. And then in this lecture, the first couple slides, I just want to give you an idea what the removable partial denture statistics looks like, both in US and in Africa. And then I'll go over the definition of biomechanics, what that means. And how do we consider, what are the considerations that we're going to have from a biomechanical perspective in removable partial denture? And I will go over, because as we think about the biomechanics, we're looking at the living structures and then mechanical forces. So now we're briefly going to go over how these support structures, both teeth, bone, and mucosa, are going to respond differently under the mechanical loading. And then the last part of the presentation, as I said, this is like a basic course, is the foundational course. So I'll just briefly go over the design considerations for tooth-borne and tooth mucosa-borne partial dentures. So for a lot of you, it's going to be just a refresher, which you already probably have been taught about these. So just to give you some numbers, in terms of the RPD statistics from the US, so there's a good number that it's actually, the number is even going to increase up to 200 million in the next 15 years. And So the other unfortunate thing with the removable partial dentures or the complete edentalism is really affecting the aging. Obviously, the more we live, we're going to use our teeth more and we're going to lose them more. But also it affects mostly the economically disadvantaged. So that's really the unfortunate part. It's mostly related to the access to care, which is still an issue across the whole global. And in terms of the number of people that are wearing partial dentures, about 6% of the US adult population is wearing them, which is approximately about 18.5 million. And then the average RPD patient, even if we say the partially dentures or completely dentures affecting the aging more, still the average age of the RPD patient is about 40 years old. So it's not, we're really just purely treating people over 65. So what about in Africa? So I did a little bit of research just to find out like the statistics number, and unfortunately I couldn't find like one study that looks at this whole like anticipated numbers in the foreseeable future. But there were really a couple of good studies that looked at the trends in the prosthetic rehabilitation, as well as what the people's responses to losing their teeth. So this study actually is from Nigeria. It's from the University of Ibadan, and if any of these doctors are in the presentation, please feel free to chime in. So what they did is they looked at the trend in prosthetic rehabilitation of partially dentures patients in the Nigerian teaching hospital. And actually these results, the next two slides, are probably more for me than it is for you. Most likely you know these results by now. But what they did is they looked at 1,518 patients between 2008 to 2014. And what they found is really 97% of these patients received removable partial dentures. So as an RPD faculty, I was like very happy to hear that. But it also shows us that really because of the access to care and the limitations in the finances, that trend in, my understanding is in Africa is still with the removable appliances more so than it is with the fixed or the implant. And this graphic was from their article, and you can see that there's a huge difference in terms of the treatment that's been offered to the patients. And as I read through the article, my understanding was also depending on where you are in the region, you might get better access. In other words, for example, Lagos, it was in the article that had more implant cases than any other part in Nigeria. So those were like really interesting, as I said, findings for me, maybe more than for you. So the other one that I also wanted to find out, we know that, yes, we're going to lose teeth, but what is really the patients feel about that? So this article was also from Nigeria, and from both dental schools there, from University of Lagos and University of Ibadan, and they looked at the impact of tooth loss on individuals on the unrestored partially dentulous arch. There was one clinician that was calibrated and trained and did a questionnaire. And they looked at the socio-demographics, the duration and the causes of the tooth loss, and the reason for replacement. As I look at the findings, one thing that caught my attention, for number one reason for tooth loss in Nigeria, based on their survey, was, or the pool that they looked at, which is, it's a smaller patient population, or the study pool, but again, it gives a little bit of an idea. Number one reason was caries. But number two reason, which is, so number one was about 41% people lost their teeth due to caries. But the second reason, which I found very interesting, was trauma. About 30% of the people lost their teeth because of trauma. And then perio and other factors followed. And then in terms of the, what does people feel, or the negative impact on their like smile, speech, and mastication, as you can see, a majority of the people didn't say that it had a negative effect on them on their smile. So only 16% said it had a negative effect on their smile. Speech was less, about 10%. The number that you see that maybe directed people more towards replacing their teeth were mastication. And I was, as I read through the article, in the discussion portion, what they mentioned is the type of the diet. They mentioned that the Nigerian diet is a hard food, so people will have hard time, obviously chewing, because it's not a soft diet. So that's why people responded more towards the negative impact on mastication, based and one of the reasons that they might consider replacing their teeth. And then the confidence of it, which is a good thing, in a way that that their confidence was not affected by losing their teeth. And then what. In their conclusion, what they said is really the reason not replacing was because of the indifferent attitude. So about 50% of the people was not bothered by not having their replaced, by having their teeth missing and feeling the need to replace them. And about 24% of them is the lack of awareness, not knowing the options And if they choose to replace it, one of the number one reason, obviously, aesthetics, which is like, I think it's a global reason for teeth replacement. So those two, I think, as I said, I learned a little bit about, the region and the understanding. So again, we'll, as we go into the biomechanics and the removable partial denture, as we know from all the studies, the studies that looked at the outcome assessment of the RPD education in terms of surveys, looking at how much the dentist put input in the work authorization form after they graduate. About 65% of these prescriptions has little or no input from the clinician. So in other words, of all the things we learn in removable partial denture, somehow it evaporates when we graduate. And part of it is really, it is not that it's complex, it is because there's a lot of factors to think about. And it doesn't always present with this, like these four perfect classification. It doesn't always like the teeth are going to be just missing on bilaterally, or you're just going to have like 4 teeth missing in one arch or 3 teeth missing in one arch. Even again, as we know that the Kennedy classification is one of the classifications. There are other classifications that looks at the partially edentulous arch. But if you think about like a permutation and combination of these missing teeth and edentulous areas, or remaining teeth and edentulous areas, there's about 65,000 different configurations. So if you think about it, technically there could be like 65,000 different RPD designs. But again, our goal as studying the removable partial dentures is really, we won't be able to give you just one direct answer. This is the only way to design a removable partial denture. Or if you follow this route, if you follow these exact 5 steps, and if you use this class here, this framework here, you're going to get to the ideal design. And in one of the textbooks by McCracken, they explain, for example, there are 2 terms in the engineering principles that are used in terms of the design process, which are applicable to the removable partial dentures. They're called the open-ended and ill-structured. By open-ended means is, again, with these 65 different configurations, the RPD design is an open-ended design. In other words, by applying the core principles, you can come up with different solutions. And RPD design process, like engineering principles, is also an ill-structured design process, which means you won't exactly use a mathematical equation to get to the end result. There are, based on the different solutions or different options, there might be a couple other considerations that you have to take. And especially in the mouth, it's totally even becomes much more complicated, because it's not only engineering, but now you also have the living structures that are going to respond to these forces and these equations that you would try to put together. So what is biomechanics then? The Glossary of Prosthodontic Terms in the 9th edition 2017, it gets updated, but it's the similar definition over the years. It's basically the application of these mechanical laws to the living structures. And in other words, it's the application of these principles to the living organisms. So the way to really understand the biomechanics in removable partial denture, first we have to look how the supporting structures are going to respond under force, and we also have to take a look what forces there are there, so that we can come up with a good understanding of how we can design the best or the most favorable for that specific partial denture case. So as we start on understanding the biomechanics, it's important to take a look at the anatomical planes, because typically these planes are there to guide us, give us information about the location of the organs, obviously, as well as the direction of the forces. So typically there are 3 anatomical planes, as you remember. There's a mid-sagittal plane, which will basically divide your body into right and left. We have a horizontal plane, which will divide our body, as you call it, like a cranial or a caudal, or like a superior inferior. And we also have the coronal plane, which will divide our body anterior posteriorly. And things are going to rotate around these three planes because we have obviously as I'm talking right now, my mandible is opening and closing. I go to maximum protrusion, so it's not only these three planes, but there are axes that are prosthesis, our jaw, or if you put a denture, if you put an implant retained prosthesis, if you put like a long span fixed partial denture, those all will be subject to these forces that are going to be coming from these different axes. So if you look at the axis, the axis of rotations are always going to be perpendicular to the plane. So from a horizontal plane, you're going to have the vertical axis. So any horizontal force to the prosthesis, which means it's going to make your prosthesis rotate around the vertical axis, which means your prosthesis is going to rotate bacolingually. Then if you look at your horizontal axis, which will be perpendicular to the sagittal plane, so any right to left movement, which is unilateral loading on your removable partial denture, or like or the load that goes across the crest of the ridge, your prosthesis is going to then rotate around the horizontal axis, which means anterior posteriorly, which is one of the most things that we talk about is the fulcrum line. And then your prosthesis, if you get those forces through the coronal plane, perpendicular to the coronal plane, which will be then the sagittal axis. Your prosthesis is going to rotate around the sagittal axis, which will be, again, unilateral loading. Your one side of the prosthesis is going to go down, and then the other side of the prosthesis is going to go up. So if you think about removable partial denture, as I said, the mandible is going to, or again, in the prosthesis, if it's the maxilla or mandible, there's going to be these rotational movements around the frontal axis, rotational movements around the horizontal axis, anterior posteriorly, and unilaterally, right? Like right to left. So if you have a tooth-supported partial, it is not a big deal because you have teeth on either side that will minimize these rotational movements. But if you have a tooth mucosa-borne partial denture, then it's a total different story because now you have a totally two different structure that have to react. That's the expectation, right? Because it's a single appliance, it is a connected appliance, it's one piece. It has to work as a one unit. But the forces are not the same, and the way that teeth and tissues are going to react to the forces are not the same. But in a way, you're going to control that as best as you can so that you're not overloading the mucosa, causing ulceration and bone loss, or you're not overloading the teeth and causing teeth mobility and bone loss and periodontal disease. So that's why it becomes a little bit harder to design the removable partial denture. And as part of the presentation, Dr. Stralta mentioned, she shared a very nice case where she also shared the experience that the patient had with the removable partial denture. It was a bilateral distal extension case. The patient absolutely hated it. So obviously there was a framework in the case. There was, I don't know the details how the prostheses were made. It was made in private practice before the patient saw Dr. Stralta. But and this is the same story that you're going to hear from a lot of patients that, the removable appliance that they get, they hate it. And we all assume that because it's a removable appliance, of course they're going to hate it. But really, if you apply the good understanding of how we can really distribute these forces, how we can minimize the teeth movement, how we can minimize the base movement, and how we can minimize the forces in obviously controlling the occlusal and occlusion factors and getting a harmonious occlusion, you can really get a very nice, stable, comfortable prosthesis for the patient. Obviously it's always going to be removable. If the patient hates the fact that it's removable, it's a different story. But in other words, I don't want us to fixate that people are going to hate removal because it's removable. They might hate the removal because the removal is not comfortable to them because these principles are not applied accordingly. So again, as I said, the removable partial denture is going to rotate back and forth. There's going to be unilateral loading on one side that's going to cause the rotation and lifting of the prosthesis on the other side. And it's also going to be bacolingual movement. But it's always not like that, right? As we open and close, it is not only these three planes, it's not only X, Y, Z axis that is going to rotate. This is the envelope of motion that you see in here. It's the Possel's diagram that we all know, the envelope of motion, maximum protrusion, CR, CO, and then we come back to the, again, the maximum opening. So, but if you can just look at that diagram there, you're going to see that it's not that or the animation. It's not that simple. It is not just, the forces are not going to be coming from these 3 locations. It's going to be coming from multiple areas. And our goal is to really distribute as best as we can when these forces are happening. So if you just like a basic refresher, if we go into the 3 groups of the forces that are going to be focusing on the removal partial denture, it is also important to really understand that even if, along with having different forces, the magnitude of the force is going to be different. So in other words, a removable partial denture might not be successful to one patient because maybe patient had really high bite forces. So the magnitude of force, even if it's the same candy classification, even if you do 10 different partial dentures, same design, patient responses are going to be different because the type of, the magnitude of force that they're going to be applying in each specific case is going to be different. The direction of the force is going to be different. They might maybe chew in a certain way. You know, we know that the class 3 skeletal class 3 patients are more vertical chewers, right? So not even the same skeletal classification, you have the same chewing cycle. The duration is going to be important. You might get these patients that sleep with their partial dentures. So, you know, 24-hour contact versus just eating and speaking contact. And obviously the frequency of that. So, you know, as I said, it's not just understanding the forces, but also understanding the factors that go along the forces is an important thing. And that's why it becomes a little bit of an ill structure. So if you think about the forces acting on the RPD, that also goes in hand with the requirements of the RPD. There's, as I said, there's going to be horizontal forces. Your prosthesis is going to move right to left. So therefore, your prosthesis has to be stable. You have to incorporate proximal plates. You have to incorporate bracing arms. You have to incorporate, you know, proper extensions, especially for the mandible in the mylohyoid region, as well as the buccal shelf coverage. So that helps that buccolingual movement. And your prosthesis, you know, obviously this is a maxilla, for example. Even if the patient doesn't do anything, it goes against the gravity, right? So the vertical dislodging forces, that prosthesis would always want to come down because it's against the gravity. So then your goal is to provide retention to the prosthesis, which means you have to incorporate clasp assemblies. You have to incorporate indirect retainers and the long guiding planes along with the proximal plates so that your prosthesis can stay in there. And then vertical seating forces, the patient's going to be biting on it, right? So we want the prosthesis to be supported by teeth and by supporting structures when the patient is biting down so that things are distributed evenly or equitably. You will never be able to do evenly, which I'm going to share the reasons for that, but it is equitable across the arch, across the teeth as much as you can. So with these 3 requirements of the removable partial denture, the components that you learned in your courses, you're basically putting the pieces of the puzzle together. Each of those components is one piece of the puzzle, and each of them are going to be acting for either the seating force or either the retention or either the stability of the removable partial denture. So these 3 things, the requirements of the removable partial denture has to work hand in hand. If you take one of these wheels out, your prosthesis is going to fail. The whole, as I said, it's, when you think about an engineering, this is an example of the machine. It has to continuously work. And if you take one of these wheels out, it's not going to work. If you don't place rest seats, you take the support out from this equation. Now your prosthesis, even if it's retentive and stable, it's not going to distribute the force. So when the patient is biting down, it's going to lose, the rest seats are going to lose its contact with the, so the clasp systems are going to lose its contact with the teeth because you don't have rest to even that out over the long term of use. If you take retention out of this, obviously the patients, you know, that's number one, the patients are going to hate you because the prosthesis doesn't stay in there when the patient is trying to talk, you know. So, and if you take, for example, stability out of the equation, when the patient is chewing on the right side, the left side is going to go up and the food is going to get underneath. And I can tell you they're going to just take the partial out and put it on the bench or on their table, or they're just going to tuck it away in one of the drawers and never use it. So it's really those 3 requirements, the components that help on these requirements have to be thought very carefully as we apply the design principles. So now let's talk about the biomechanics of the considerations for the removable partial denture. As we go into that, I just want to go over the biomechanical classification. So as we know, there are 3 types of main use classifications. One is the biomechanical, the other one Kennedy, which I shared, and then the third one is the ACP classification, which I strongly urge you to look at that. It's by the American College of Prosthodontists that looks at the risk factors in terms of the classification. That is really, really helpful in terms of the risk assessment for the RPDs. But for today's presentation, I'm just going to be focusing on the classification based on the supporting structures, which is the biomechanical classification. So if you have a tooth-borne partial denture, you have teeth on either side of the edentulous area. So the patient is missing a number of teeth, certain teeth, but you have teeth, abutment teeth bounding that space. And now you also have, depending on the supporting structure, your prosthesis could be also tooth mucosa borne, which means it has to be supported by teeth as well as the mucosa. And that's the example is given for this type of prosthesis, obviously, in the class 1, in the class 2 cases. The third classification, which I did not even put in the slide, is the mucosa borne, which means your prosthesis is not supported by teeth, and that's basically the interim, the provisional flippers that, or the provisional removal partial dentures that we use that are not meant for long term, which are only have just maybe rolled wire clasp and acrylic. There is really no understanding of the rest seat placement and the plating and all the other factors. So the next thing, as I said, now we talked about the forces, especially for a tooth mucosa borne partial denture. Then also we have to understand you have two supporting structures. So then you have to understand how they would act when the patient bites down, because you cannot tell the patient when you make a prosthesis just bite on the denture base or just bite on the teeth. They're going to put the food bolus in there and they're going to put their teeth together. Part of the food is going to contact the teeth and part of the food is going to contact the mucosa. So this diagram is from the McCracken's book, and if you look at it, and this is, the information as we already know, the teeth are in their socket, tooth socket with the PDL around them and the alveolar bone supporting it. And then on the bone, you have the connective tissue and mucosa. Obviously, in certain cases, you have the submucosa too. On an average, the mucosa thickness is about 2 millimeters. It might go even much more in certain areas, such as tuberosity. And the PDL thickness about, or the width is about 0.25, 1/4 of a millimeter, plus minus 0.1 millimeter. Under 4 pounds of force, the teeth will then intrude in the socket about 20 microns. But as I said, you cannot just, we don't have smart food at this point. The food is not just going to go to the teeth. It is also going to go to the mucosa at the same time that the patient is biting down. But with the same amount of force, which is 4 newtons, as I said, your mucosa can displace up to 500 microns, which means on the same side of the mouth where you have a tooth and a distal extension area, your denture base could displace up to 25 times. These are average numbers. It will depend on the magnitude of force. It will depend on the mucosa thickness. It will depend on the location of the or the distance from the cantilever where that bite force is. But this just tells you that the teeth and the mucosa are not going to act the same way under force. But in a way, you want them to act at least similar within their threshold. You want the mucosa not to be overloaded, because then you know that the force, if that overload exceeds its threshold level, then it's going to transmit that compressive pressure force to the bone, and it might cause like first mucosal ulceration and then down the line mucosal bone loss. If you overload the teeth, we know that you get tooth mobility. And if you add the fact that the patient cannot take care of their teeth, if you add the periodontal disease into it, then you look into tooth loss. So that's, it's important to understand where that comes from. This also, shows you that the length of the denture base also tells you how the components are going to slide on the teeth. For example, as I said, like a 2 millimeter tissue displacement, for example, on a base that is about 30 millimeters long, your proximal plate on where it's on the C could go down about 0.25 millimeter. So because it's the force factors, it's an arc. It depends on what the patient bites down. If it's opposing a denture, you might see less, versus if it's opposing a fixed implant arch, then you're going to see more tissue displacement. So it's important to understand these force factors. It is important to understand how the teeth and the mucosa are going to react under different forces. It's really important from the removal partial denture design process. And also, Not every, as I said, not every mucosa and bone are going to react the same. So if you look at, for example, in the B area, if you have a flat ridge with a thick keratinized tissue, that area of the mucosa is going to be more bearable, or it's going to be more patient with the loads, versus if you get a thin ridge, if you look at the C, for example, if you get a thin ridge with a sharp bone and a thin tissue on top of it, that patient might not be very comfortable under biting. So you get poor support from the mucosa. And or if you have, like if you see in D, for example, if you have a mucosa that is thicker and displaceable, then it's not a good support for your prosthesis. So as we talk about the tooth mucosa bone partial denture, as you can see, even within the same area or in the same patient, in the same mouth, not even the tooth mucosa bone is the same tooth mucosa bone, depending on where the mucosa is. So now let's also talk about the application of so we talked about how the biological part, the supporting structures are going to react. We talked about where the forces are going to come from. Now let's talk about what the mechanical portion is going to act like. So you remember these 6 simple machines from your physics course. So the 2 ones that you see here, the inclined plane, which is applicable more towards the positive rest seat application, and the levers are the most applicable of in the removable partial dentures. So for today's presentation, because of the time limits, I'm just going to go over the levers for today. So again, basic reminder from your physics class, you have a class 1 lever. So you have resistance on one end, and then you have power on the other end. This is the perfect example to this is the seesaw or the teeter-totter at the playground, right? So your friend goes down, you go up, the fulcrum is in the middle. The class 2 lever, you have the fulcrum at the tip. So the wheelbarrow example is usually given for that. So as you see in the slide, the wheelbarrow, the fulcrum line, which is the point of contact with the ground, is at the tip of the wheelbarrow. Your resistance, which is the load, is in the center. And then your power, where you basically lift the load up, is the opposite side of the fulcrum line. So, and then we also have the class 3 levers, which you have also the fulcrum line in this case on one end, but this time around you have the power in the middle, and now you have resistance on the other end. So really there is not much mechanical advantage in this type of lever systems. So the nutcracker or the fishing pole, those are all examples of the class 3 levers. So now let's take a look to see with our design how these would look like in the partial denture. So as I said, class 1 lever, the fulcrum line is in the middle, you have resistance on one end and you have power on the other end. So if you look at this extension case, then if I place the rest seats on the distal, then that becomes my fulcrum line, right? We know as a definition of the fulcrum line is determined by the most posterior rests on either side of the arch. So if you have the fulcrum line in the middle, when the patient is biting down on the distal extension, what will happen? Because they're going in opposite directions, right? Your resistance is going to go up. When the patient is biting down, your clasp will engage the tooth. Is this something that you want? Not really, right? We want the retention when the denture base moves away from the mucosa. This is actually the opposite how we want things to work. But the moment you put the fulcrum line in the middle, this becomes inevitable. That's the levers that you create in your designs. And also, as I said, because they work there on the other side of the fulcrum line, if the patient is, let's say, eating something sticky, then the denture base goes up, then this clasp would go down, disengage from the tooth. So then, but when the base goes up, let's say when the patient is biting something sticky, we want the clasp engage the tooth, right? Because we want the retention. So now by just putting the fulcrum line in the middle, first of all, you put extra force on your teeth, and also you make your components not work the same as you want them to work. You want that clasp to engage when the base goes up. So you want them to move up at the same time. But because the fulcrum line is in the middle, it becomes, from a mechanical perspective, it becomes almost impossible to get an ideally working partial. So then, the philosophy that was, obviously developed in the literature you read from Cradleville, Kroll, really expanded that into the RPI design. A lot of other literature that you remember, Thompson's article that looked at the mesial rest, that it provides really the forces on the most vertical. Again, Caputo's and Nally's article, they all looked at the importance of the mesial rest location. And the idea behind all these studies are to move that class 1 lever into a class 2 lever, to move that fulcrum line anterior. By doing that, now your resistance and power are on the same end of the equation. So let's take a look at what will happen based on this. So if you move the fulcrum line to the mesial, in this case, when the denture base comes down, your clasp is going to engage the tooth. And that's exactly what you want to do. Because you want to make sure that the prosthesis stays in there. The clasp is sending engages the tooth when there's any displacement forces on it. The other thing is also when the patient is biting down, if this goes up, the resistance is going to go up, which means the resistance is going to disengage from the tooth. Your clasp tip is going to become not contacting the teeth, and that's exactly what you want, because when the patient is biting down, you don't want any retentive forces. You want support, right? Your rest teeth should work, not the clasp. So by just changing the location of the fulcrum line, now you made your prosthesis obviously more retentive, and you also made your prosthesis so that it's less forces to the teeth. And the class 3 lever, which is more applicable in a tooth-borne partial dentures in the class 3 cases, where you have the fulcrum line on one end, your power is in the center, which is in between the two teeth, and then your resistance is on the other end. So with this type of prosthesis, the detrimental forces are not much at all. There's not a lot of rotational forces to the type of the prosthesis. So in fact, tooth-borne partial dentures are probably one of the easiest to design by applying all these principles. It's obvious if you still meet the requirements. So I'm going to just go over a little bit about now, so we talked about moving the mesial fulcrum line to the mesial, and now I want to talk about, if you move that fulcrum line further by placing an indirect retainer, what changes you see. So these images are from the ehuman.com. It's the removable partial denture interactive software. If you haven't looked at it, I encourage you to do so. And again, I don't have any conflict of interest with that system, but they were gracious enough for letting me to use their animations as well as their images. So now let's take a look. So besides, for this design, for example, initially we had a rest on the mesial. So we did that to be able to make our resistant, the clasp tip more effective. And now we decided we're going to add another indirect retainer, further away from the fulcrum line. So by doing that, let's take a look to see what's really happening. By doing that, what we did is we increased our resistance arm. So as you remember from your physics, there is a power arm and there's a resistance arm. Depending on where you put the load, you can really make it more mechanical advantage. In other words, when you do the wheelbarrow, for example, depending on where you put the load on your wheelbarrow, you can easily carry it, and sometimes it might not be that easy to carry it. And the same thing with the nutcracker, right? Depending on where you put the nuts in the nutcracker for class 3 lever, it might make it easier to crack it. You don't place it at the tip, at the handle, you place it closer to the fulcrum. So same thing for the the class 2 levers, is by moving that fulcrum line, what you did is you increase your resistance arm, but you also increase your power arm. So because you did that, if you don't take measures, your prosthesis doesn't get really affected by the location of the indirect retainer. Yes, it becomes more effective, but you really have to take a look to see where the power arm is located to be able to do that. So this graphic really explains a little bit better. So if you look at it, for example, as I said, first you have the resistance arm, which is from the clasp tip to the indirect retainer, and you have the power arm, which is from the load, displacement load, to the fulcrum line. And here, as you look at it, depending on where you put that indirect retainer, which, for example, in this case, if you look at fulcrum 2, which is the option 2, that resistance arm is shorter, right? Versus if you place that indirect retainer further away from the fulcrum line, that resistance arm becomes longer. And the same thing, also your power arm, if you place it onto the option, 2 case, in the mesial of the first premolar versus distal of the first premolar, your mechanical advantage changes. So what we're trying to say is, yes, you're going to be, when you design your prosthesis, you're going to put your indirect retainer as further away from the fulcrum line as possible. But keep in mind, because the fact that you're increasing your power arm, you might not see that much of a difference. And that's why with the removal partial denture design process, you're going to see that a lot of the authors talk about shortening the mesiodistal width of the denture teeth. Not the base, again, because obviously you want to get, with the snowshoe principle, you want to distribute the force as much further around the supporting structures, but also what you want to do is like minimize that power arm. So by minimizing the mesiodistal width of the denture tooth, what you're doing is you're minimizing the power, and by placing your indirect retainer as further away from the fulcrum line, you're increasing your resistance arm. So now your prosthesis becomes very stable. So in terms of the equation that you remember from physics, the mechanical advantage that you're looking for removable partial denture should be the lower you have it, the better. Because if you have a higher mechanical advantage, that means your denture base is going to go up higher. So now let's take a look at this animation here. Take a look at the displacement on the distal extension area. If you have it on the mesial of the first premolar indirect retainer, we'll take a look at the amount of displacement on the distal extension. And by getting your indirect retainer further away from the fulcrum line, by increasing that resistance arm, you're also getting less displacement. And that's why the effectiveness of the indirect retainer increases as it goes away from the fulcrum line. This was also a nice animation that talks about the location. If you put a rest on the mesial versus a distal rest, it was first, it's a flash file developed by Dr. Schmidt. He was a former graduate of the Indiana University graduate program, and Dr. Loney from Dalhousie University. He has received the permission to use this, and he shares it on his website. So his website is also another great resource to look at for removal partial denture education. So if you look at this flash file now, the red bullseye shows you the point of fulcrum line, right? So if you have on a mesial rest, take a look to see how the clasp goes down, right? Because it's a class 2 lever now. The denture base goes down, the resistance goes down. And now let's take a look to see if you place it on the distal. If you place a distal rest, now it becomes a class 1 lever. The base goes down, the resistance goes down. So I think, I'm hoping that this also might be a good animation for you to understand the importance of the levers in removal partial denture design, why we're really stressing that it should be placed more in the mesial versus the distal. And I'm also going to go over, it is not always like really written in stone. There are cases that you might have to choose a distal rest, but it's important to understand where the forces are applied, what the fulcrum line that you're trying to create with that prosthesis. So the next part of the presentation, with the next couple of slides, I just want to share with you the design considerations. Like this is going to be more like a summary or a checklist that you already learned in your removal partial denture courses. So from a biomechanical perspective, as I said, we divide our prosthesis either a tooth-borne or a tooth mucosa-borne. So for the tooth-borne partial dentures, the number one that you're going to deal with is the Canada Class 3. And not always it's going to be the exact same Canada Class 3. Keep in mind, every patient is different depending on their occlusion, depending on their, obviously opposing occlusion, depending on the number of teeth that are missing, depending on the condition of the remaining teeth, depending on the occlusal plane. There's a lot of risk factors that will play into the design process. But the next couple of slides, the guidelines, just give you a brief idea what things that you should consider. Number one is rotational forces are insignificant, which means from an indirect retainer, because you'd consider that mostly in relation to the fulcrum line, that because the rotations are minimal, you really don't have to use an indirect retainer for the tooth-borne partial dentures. And then in terms of the major connector, when you're dealing with a maxillary case, you don't need a lot of support from the mucosa. So for the maxillary major connectors, strap design, minimal coverage on the palate is just enough to connect the pieces together. Obviously, you're going to have to still make sure that it is within certain dimensions, within like 8 to 12. You can have the lab technician to increase the center to 1.5 millimeters to make it more rigid, but you don't necessarily have to turn it into a plate. However, if you expect or anticipate that you're going to lose some of the abutment teeth, you could then maybe consider plating the lingual surface of those teeth. The location of the dentures areas are going to dictate what type of strap you're going to use. Are you going to use an anterior strap, or are you going to use a posterior strap? If you have missing teeth in the anterior, obviously it makes sense to use an anterior strap because your major connector has to be closer to the dentures area. If you have posterior teeth missing, then you're going to use a posterior strap. If you have tori, you could then maybe use an anterior posterior strap versus covering obviously the tori. And the patient preference is an important factor to consider. You know, we always recommend to refer to the patient existing partial denture, especially if it fulfills the requirements of removable partial denture. It is important to look at it because a lot of the maxillary major connectors are also going to deal with the speech zone. If the patient is really having comfortable and adapted their speech to a certain amount of coverage in the palate and the location, it is important to understand that by doing any changes into that speech zone, there is a chance that you might also change the speech adaptation for the removal for that patient. So, you know, just keep that in mind. And what about the mandible? As you remember, there's going to be mandibular major connectors are not like maxillary major connectors. I always give this example to the students. As we think about the support from the mucosa, it is important that we also have to rely on a bone that's always going to be there. The maxillary major connectors are contacting the palate, which is always going to be there. It is like your best friend, your family member, that is always going to be there. So like you do with your family member or your best friend, you're always in contact, right? That intimate contact, it's important. Close contact, it's important so that you get support. And that's exactly the same thing for maxillary major connector. Whereas the mandibular major connector, there's an unfortunate part with them because where the major connector is going to touch is the alveolar bone and you have a thin tissue on top of it. So unfortunately, that relationship cannot be that close because any close contact in that area with any rotation of the prosthesis, even if it's very minimal, it might cause some ulcerations and irritation to the tissue. So therefore, all the mandibular major connectors, regardless tooth-borne or tooth mucosa-borne, they are going to have some kind of a relief. But when you're dealing with tooth-borne, because that rotation is very minimal, you really have to look for like a thin layer of wax relief underneath that area, which the recommendation is about 30 gauge. And so the next thing is the functional depth of the lingual vestibule. Obviously, those magic numbers are based on the distance that you have to keep away from the pharyngeal margin, which is about on an average 3 millimeters for the mandibular cases. And if you add the minimal width, superior inferior width of a lingual bar, then the number comes up to 7. So if you have 7 or more, you can use a lingual bar. If you have between 5 to 7, you can choose a sublingual bar or lingual plate, or if you have anything less than 5, then it becomes a lingual plate. And but there are going to be cases that you might not be able to do a lingual location of the major connector, so then you might have to revert to the labial part, which then becomes a little bit more flexible type of major connector, and the compliance rate is very poor, but that's an option. And if the patient has tori that you can manage with your removable partial denture that doesn't require an absolute tori removal, then the recommendation is to use the plate because then you can drape over the tori in that area. And obviously, if you anticipate the loss of natural teeth, even if you have enough vestibular depth, then you might consider the lingual plate instead of the lingual bar. In terms of the clasp assembly selection, minimal tooth and minimal tissue coverage, I think that's the key in removable partial denture design, regardless of the case that you're working in, because we know that the removable partial denture will increase risk for caries, will increase risk for periodontal disease, and our goal as clinician is to really try to preserve the teeth and the tissues as well, as much possible as in the long term. So minimal tissue and minimal tooth coverage will minimize those risks. Aesthetics of smile line, obviously we know that if the patient doesn't have a gummy smile line, or if that doesn't have a very hyperactive upper lip, a bar clasp is going to be more aesthetic. As you can see in this picture, for example, the patient, when they are smiling, they're not showing much of the maxilla. So if you choose an I-bar clasp assembly, which is the case in this case, the patient can really hide those bar clasps, so that it's easier from an aesthetic standpoint. The location of undercut is going to help you determine whether or not if you're going to be able to use a ring clasp, or you're going to be able to use a T-bar. So where that location, is it in the mesial, distal, is it in the buccal, or the lingual, is going to guide you where that clasp assembly can be used. And if the patient's periodontal status of the abutment teeth, if it's compromised, obviously you always want to make sure that your patient is caries-free and periodontal stable before you move with the removal partial denture. But even if they're periodontal stable, their periodontal status might be compromised. So in those cases, our recommendation is trying to use as many teeth as possible within the limits, obviously, so that you can distribute the force. So multiple rests recommended, and a bilateral bracing, which is circumferential clasp assembly, so that you can stabilize the teeth. So the commonly clasp assemblies that are used for the tooth-borne removal partial denture, you can use a castor-circumferential clasp assembly, which means you will have a castor-circumferential clasp assembly as your retentive arm, and castor-circumferential clasp assembly as your reciprocal arm. As I said, for cases for minimal tooth coverage or aesthetic cases, you might maybe choose the I-bar as your retentive arm and your circumferential as your reciprocal arm. And or you could also use embrasure clasp assembly, which is usually limited in cases of the Candy Class 3 cases on the non-modification side. So this just a diagram that shows you where the clasps could be located, which could be your potential abutment teeth, and then if you're going to be considering indirect retainer or not. So usually for Candy Class 3, if you have a modification, then obviously the arrows point out to the potential location for the clasp assemblies, as well as your obviously your rests. And so if you don't have a modification, the arrow on the upper left side here, this is a perfect location for an embrasure clasp assembly. And you can put use the other clasp assemblies that I shared with you, either cast I-bar and a cast circumferential, or a cast circumferential clasp assembly for the molar in the upper. If you have modification, then it becomes a quadrilateral positioning. So you have 4 clasp assemblies on either end, and again, indirect retention is not necessary because you really don't have a lot of rotation around the fulcrum line. And when possible, it just makes sense to place the rest teeth adjacent to the edentulous area so that you can direct the forces along the long axis of the teeth. In Candy Class 4, which I'm not going to go into detail because a lot of the Candy Class 4 cases could be designed by the rotational path partial denture design, which gives you 2 paths of insertion for your removal partial denture. But just for today's presentation, if you choose to treat it as a conventional clasp, in other words, if you're not going to eliminate the clasps in the anterior as you do in rotational path, then you're going to have to place these 2 clasp assemblies as anterior as possible, which will be on the 2 far front arrows that you see. And now you're going to place the clasp assemblies as further as possible. One thing to keep in mind, even if we put tooth class 4 in a tooth-borne, it is almost treated as a tooth mucosa bone, especially if you have a long span edentulous area in the anterior portion of the mouth, because then it becomes a mesial extension, not a distal extension. And in terms of the denture base, you have 2 options. You can either have like a resin base, which will be lattice and mesh wrapped around with acrylic, as you see in the top picture, or you could also use a metal base, as you can see on the bottom picture, left side of the slide. So the resin base is usually preferred in long span because with the resin base, which means you still have a metal framework, but you have acrylic contact in the mucosa, it is easier to reline. If you are expecting that that there's going to be a lot of bone changes that you need to compensate for over time, bone and mucosa changes, then you really have to consider the resin base so you can reline. And in cases where you have really a sharp ridge and a thin tissue on top of it, you might want to maybe consider a resin base because then it's easier to adjust acrylic versus it's almost impossible to adjust from cobalt. But you can choose the metal base. In other words, you can have the metal contact the tissue when you have short span, you don't have a lot of inter-arch space, or you don't anticipate the need for reline. But just keep in mind that you cannot reline the metal base and you cannot adjust. But metal base, obviously, from a tissue health perspective, it's not going to be as porous as acrylic, so the tissue tends to be a little bit healthier underneath the metal base. So now the struggle becomes the design considerations for the tooth mucosa bone partial dentures. So the two main classifications are the Canada Class 1 and Canada Class 2. And all the things that I talked earlier in the beginning of the presentation, where the forces are coming from, where they're going to be located, how the teeth and mucosa are going to react to it, becomes much more critical when you're dealing with the tooth mucosa bone partial denture. But just as a reminder, as with the snowshoe principle, you know, obviously when you're walking on snow, you want a wider shoe, right, to be able to distribute forces so you don't fall down. So same thing for the major connectors. For the tooth mucosa bone, you want to apply the forces to a broader area so you get more support from the mucosa. So for the maxillary major connector, then you're going to consider plate design. By what we mean by the plate, at minimum, more than 12 to 15 millimeters of palatal coverage. And if you're going to be, and if you anticipate the loss of natural teeth, then you have to plate the lingual surface of those teeth. For the mandibular major connector, you're going to need relief. And the relief is going to be determined where your major connector in relation to the fulcrum line. It goes from 24 to 28 gauge relief. So it's much more of the space compared to the tooth-borne. And so again, the magic numbers of that 5 to 7 millimeter come again in the tooth mucosa bone because it has something to do with the depth of the vestibule. And again, as you remember, the top of your major connector in the mandible, if you're not plated, it should be at least 3 millimeters away from the pharyngeal margin, and then 4 millimeters of that lingual bar. If you add that, that becomes 7. If you don't have that, if you have 7 or more, then you're going to use a lingual bar. If you have between 5 to 7, you can use a sublingual bar, because sublingual bar can be thinner, superior, inferiorly, but you're going to make it thicker buccolingually. So sublingual bar essentially is like a lingual bar rotated 45 degrees. And then if you don't have enough vestibular depth, then you're going to have to use a lingual plate. And then obviously if you have lingual tori, then you're going to have to choose the lingual plate regardless, because that makes it easier to drape over it. One thing to keep in mind, especially in tooth mucosa bone partial denture, if you're going to plate, then you have to consider rest on either side of the plate so that the forces doesn't push the teeth buccally when it comes from the plate. So that's a very important factor to keep in mind. In terms of the denture base, at least at Michigan, our recommendation is the resin base, because we know that the tooth mucosa bone partial denture, there's going to be some bone changes over time, so you want to be able to compensate for those changes. And resin base is the only one that will let you do that, because you can reline and it's easier to adjust. In terms of the class system, you want to consider maybe an RPI and RPC, which, you know, I just went over that. Minimal tooth and minimal coverage, aesthetics, class on previous partial denture, those are all important factors to consider. But mainly what you want to focus on is the stress releasing class specimen. The location of the rest seat, the location of the fulcrum line becomes very important. So the 3 options that we use for the as class specimens for extension-based partial denture are either the RPI, which the rest is in the mesial. You have a distal proximal plate and an I-bar on the facial. There are some contraindications that you won't be able to use I-bar. In those cases, then you can use a circumferential clasp, which has a totally different design than a regular circumferential clasp, which is the RPI and RPA class specimen. Or you could also use the wrought wire, because wrought wire class specimens tend to be more flexible. So in terms of the RPI class specimen, again, this is just a refresher for all of you. The rest is again on the mesial. I hope by now that I convinced you that the location of the rest, you want to move that fulcrum line further away from the extension base, turn it into more like a class 2 lever, so that resistance arm becomes more effective and also it disengages from the tooth. You're going to have a proximal plate on the distal aspect, and you have an I-bar on the facial aspect of it. So this animation, again, as a generous permission that I received from the ehuman.com, it's their animation on their interactive software. So what it shows is basically when you, one thing that I want to show here is, let me stop here for a second. So a lot of the times with the RPI class specimen, the question becomes, while we talk about the importance of reciprocation, right? We want to make sure that when the tooth is exerted force on one end, there is another thing that holds the stabilizers on the other end. And as I just shared you with the previous slide, with the RPI design, you don't have a reciprocal arm. But then the critical part becomes is the location of your proximal plate. So the reciprocation for the RPI clasp comes from that distal lingual corner of your proximal plate. And that's what this animation is showing you. As the clasp engages the tooth, that contact of that proximal plate will help you to retain, as well as the minor connector will also provide that reciprocation to your limit. So those are the two things that, just keep in mind. And the other, if you cannot use I-bar, because we know that the bar clasp assembly comes with their contraindications. If you have soft tissue undercuts, if you have, if you don't have enough vestibular depth, if you have really tilted lingually or buccally, then you cannot use the bar clasp. Those are absolute contraindications. Then you have to switch to the RPC or an RPA design, which then you have a circumferential clasp as your retentive arm. Again, a distal proximal plate, and you have a rest seat on the mesial. And so in terms of the design, again, the rest is on the mesial. The minor connector on the lingual side here does not contact the adjacent teeth, because if it does, then it will wedge it. And then you're also going to prepare the guide plane on the occlusal 1/3 of that mesiolingual embrasure, as well as on the distal aspect of it. One thing with the RPI design is the location, the amount of guiding plane, or the location of the proximal plate. There are two philosophies in the literature. The first one by Cradoville, which he also talked about the mesial rest location. His design based on a long guiding plane, whereas the Crow's design is based on a shorter guide plane. So in Crow's design, the guiding plane, which we prepare on the teeth so that we can provide a single path of insertion to our prosthesis, and so the proximal plate can contact, is prepared on the proximal surface adjacent to the edentulous area on the occlusal 1/3, about 2 to 3 millimeters. The proximal plate only contacts that apical extent of that contact. So as you can see, it's a fairly shorter proximal plate. And it also has a vertical relief underneath. And the idea is when the patient is biting down, we don't want that the proximal plate to impinge onto the pharyngeal margin or the papilla right next to that premolar. So that's the whole philosophy behind the Crow's shorter proximal plate. Because if you do a long guiding plane, as you can see, when the patient is biting down, then because there's no relief, there is a chance, especially because we know that the mucosa can displace almost 25 times more than the teeth, or 20 times more than the teeth, then you're going to be displacing, or you're going to be putting pressure onto the pharyngeal margin. So that's the major difference between the Crow and the Cradoville design. And the idea behind the long distal guiding plane is to provide retention, because there is also literature that shows that the proximal plate would actually be almost as retentive as clasp in certain areas. We tend to place longer guide planes when it's a tooth-borne cases, and the shorter guide planes, and obviously shorter proximal plate when it's a tooth mucosa-borne partial denture cases. In terms of just another reminder into where to place the clasp, obviously your primary abutment teeth, which is the primary suspect, will be right next to the edentulous area. And you have to consider the indirect retention, because it is a must, as you know, that you really have to move that fulcrum line anterior. And but if you have class 2 cases, then because you have a unilateral in those cases, then you're going to need 3 clasp assemblies. So you're going to choose the stress releasing clasp assembly on this one over here. And now you're going to choose one on the opposite side of the arch. If you don't have modification, then choose one as posterior as possible and now one as anterior as possible. If you have modification, then obviously the teeth that are adjacent to that modification area would be easier to choose. And so the indirect retention is a must if it's kinder class 2 cases. And the indirect retention, because as I said, the fulcrum line is the most, goes through the most posterior rest on either side of the arch. So then the clasp assembly that you place, or the rest that you place on the anterior abutment teeth, becomes your indirect retention. There is also literature that shows that the clasp assembly anterior to that fulcrum line in the class 2 cases should really not engage the tooth because under forces it might be torquing the teeth, and that's obviously a totally different subject and topic, and hopefully maybe in the future we can go over that. Just keep in mind that indirect retainer is a must for all tooth mucosa bone partial denture, and it should be as further away from the fulcrum line as possible. So hopefully I shared with you just a brief overview about the biomechanical principles. The key is to really understand which teeth to choose. The key is understand what type of forces, the magnitude, location, type, duration the patient has. The key is to understand the type of mucosa. The key is to understand the patient risk factors for developing caries and periodontal disease in conjunction with removal partial denture. And the key is to understand that it is important to provide a good harmonious occlusion on this type of prosthesis. And by doing that, hopefully we would be accomplishing a good type of prosthesis that would be comfortable for the patient, aesthetic for the patient, and functional for the patient. So hopefully it's part 2 of this presentation. Next time we meet, I'll go over the digital RPD with you guys. So thank you so much for your attention and patience, and I know partials are not that easy to listen to. So with that, without further ado, I'll just stop here and I will go over our poll. So thank you. And any questions, feel free, please, to put it in the chat.
Please go ahead.
Yes. So the first question was the horizontal masticator forces may cause movement of the partial denture around the sagittal axis. So when think about the horizontal plane, the vertical axis is the one that will cause that movement, which will be, again, the buccolingual movement. So it was actually false. And the other thing that I also want to say, unfortunately, colors are not the way that Zoom looks at the poll result. The color, like you see the orange color, for example, in true, it's basically because more number of people answer to that one. But the correct answer is false for the first one, because the horizontal masticator force will cause movement of the partial denture around the vertical axis. So just keep in mind that when there's a force on the any force that's coming, it's going to rotate around an axis that's going to be perpendicular to it. So the second question is, under equal force, teeth movement will be equal to mucosal displacement. Again, this is false, because teeth are going to intrude about 20 microns, whereas the mucosa might displace up to 500 microns. So there's about 1 to 25 times difference there. The third question was, the indirect retainers are placed posterior to the fulcrum line. Again, this is false, because you want that indirect retainer as further from the fulcrum line so you can increase your resistance arm. The fourth question was, effectiveness of the indirect retainers increases as the distance from the fulcrum line increases. And that's the example that I gave, is by increasing the distance, you're increasing the resistance arm, so you're making your prosthesis obviously more retentive. So the effectiveness basically increases as the distance from the fulcrum line increases. So that was true. And question 5, which of the following clasp assemblies will be indicated on teeth adjacent to the edentulous or the disc extension base? Again, the RPI and RPD clasp assemblies are our recommendations. Embrasure clasp assembly, it's going to be too much torquing on the teeth, so that's usually used in Tooth-borne. And ring clasp is usually used in tilted molars. So those 2 answers were not correct. So the correct answer is RPI. And for question 6, what type of lever is more beneficial in tooth mucosa bone RPD case? Again, our goal in tooth mucosa bone partial dentures is to move that fulcrum line to further, which will be obviously in this, not in the middle of the resistance arm and power arm, but we want to place it further so that resistance becomes in the middle and power is on the other end, which is a class 2 lever. So the correct answer in that one is a class 2 lever. Okay.
All right. Thank you so much. I'm going to send the same questions back to you. Thank you so much, Dr. Saglik.
You're very welcome. Well, thank you all for your patience.
Dr. Weekend and Dr. Sirialta for the wonderful presentation for today. Tomorrow we have another presentation.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator